So our next talk is by Dr. Sandra ma'am. She is a consultant in pediatric ophthalmology and strabismus in Arvind Eye Hospital, Coimbatore, with a vast experience, 21 years experience. So everybody know her. Over to you, ma'am.
Thank you. So I'll be talking about one more non-surgical. Non-surgical can we say, but definitely we have to do in theatre only. But it is non-surgical in the sense if we don't open the conjunctiva. Um, it was developed for purpose of strabismus only, but it meant more now for cosmetic purposes. It was developed by Dr. Alan Scott in 1978, and he was purely a strabismologist. But in the meantime, after it was discovered, I think we have lost, and more the orbit people and cosmetology have started adopting the use of Botox. And so it was called as Botox in 1989 when Allergan acquired Oculinum from Scott. So what is it? It's a neurotoxin. I think most of the chemistry behind it will be well known. It causes chemical denervation of the motor end plate and paralyzes the muscle to relieve the spasm or the contraction. So it is by creating a denervation. So it will block the cholinergic like the nerve endings. It will enter the nerve terminal and it will be internalized and leads to something called as functional denervation. So it doesn't act forever. Its action is going to be there for a limited period of time. We say up to 3 months will be the duration of action. So we have Botox, Dysport and Myoblock available, and it has to be like if it is type A, it is available as a dry powder which you have to lyophilize with the saline and then reconstitute. So the one which I am familiar with in my hospital is the Botogini, which has a 50 units vial. So for the purpose of strabismus, I am now diluting it with 1 cc because it is easier to inject just a 0.1 cc into the muscle and it gives 5 units per 0.1. So earlier when I started, I used to try with the 2 cc dilution because the orbit were more used to this dilution. But what I found was that most of the drug was extravasating out. There is very less space within the sheath, muscle sheath. So it is much easier to inject like 0.1 and that avoids the spread of the toxin. So the dosage will be around 2.5 to 5 units per muscle maximum is what is generally used. But you can reconstitute and you can store in the not in a freezer. It is in the below until it is reconstituted. But after reconstitution, you can use it within a period of 4 hours or sometimes even 1 or 2 days later we do use it. So there are like a lot of indications for Botox in ophthalmology. I have experience only with 2 of these conditions, that is for acute 6-nerve palsy and acute comitant esotropia, and in a few cases of thyroid ophthalmopathy also I have used. I have not used so far in any case of congenital infantile esotropia, but there are a lot of reports of people also using it for infantile or any esotropia as an additive. Like you are doing 3 muscles, you can add Botox as one of the thing, but I usually don't prefer that. I have not used it for such indications. So coming to lateral rectus palsy, so lateral rectus we know, okay, mostly it is most common etiology is diabetes. So which are the cases where we are going to inject Botox? See, when we see a diabetic 6-nerve palsy, our first thought is it is going to resolve by itself. Yes, it does. In most of the cases, it is going to resolve by itself. So when you are seeing the case, if it is very mild, like the esotropia in primary position, and if the abduction deficit is only -1 or -2, when you are seeing the patient for the first time, most likely it will resolve by 2 weeks or 3 weeks or maximum 1 month. In those situations, you did not go for botulinum injection. I would reserve the injection for a large angle, is a diabetic or a mononeuropathy, where you have a larger angle at presentation with like -3 to -4 limitation of abduction, not resolving for 2 visits, then the chances of getting contracture of the antagonist is quite high. And even other thing is the rehabilitation of the patient. Like if they are active, if they are earning member, they lose the livelihood sometimes, because no person is going to give leave for 3 months for them to recover the 6-nerve palsy and come back and join their work. So that aspect also we have to think about. And in such conditions, when we give the botulinum toxin, then definitely the we hasten the recovery. So those are my thought processes when I advise Botox in diabetic mono-neuropathy. This is the thing, because in neuro clinic there is always a tug. They will say it will resolve spontaneously. We will say that there are definitely certain indications in 6-nerve palsy where we can use Botox, and rehabilitating early is very important, because I know a couple of patients who have lost the job because of this condition. And another thing is, like if you keep on waiting, the success, like even if you are going to do an R&R, it may differ. If you keep on waiting for 6 months till it doesn't recover, then you are forced to do a muscle transplant. Like you have to do some transplantation process. Then instead of that, you can easily do an R&R if you get some degree of recovery. So the success of your surgery also differs. This holds more in cases of third nerve palsy. Now, in couple of cases of third nerve palsy also I have injected botulinum toxin, where it prevents the contracture of the lateral rectus. So later on when we do surgery, it is very easy. And sometimes the recovery is also there. So our surgical decision becomes R&R instead of going for some other procedures. So double vision is extremely distressing. You can probably try sticking on one prism to one of your eye and seeing. We get headache, we get nausea, we get migraine. We cannot stand that double vision even for couple of minutes. It is extremely distressing condition, and you are totally inability to and you are totally dependent on somebody, except in the very mild cases of 6-nerve where you can adopt a face turn and you can walk. That way is fine, but otherwise it's really distressing. It causes stress, it causes depression. So yeah, this is what I was talking about. So initially when I started out, used to give a small nick. This was many years ago, almost 10 years ago, when I was working with 6-nerve. All my experience with Botox initially was with 6-nerve palsy. So I used to make a small nick in the inferior fornix, just as how we would approach a surgery, and then under direct visualization used to inject. So we are using now, you can see the 30 gauge needle. Initially started out with the 25, then moved to 27, then to 30. Again, because the hole that you are making in the muscle sheath, it is good if you can use a thinner needle. And also don't take out the needle immediately. Once you inject, you just wait, and then you take and then to take it out slowly. Don't immediately compress it the cotton, because then again everything is going to come out, especially if you are going to give a open sky technique. So this is like a patient, you can see 20 prisms, and 1 month after Botox he is completely, his abduction has come from -3 to fully recovered. So then coming to Botox in acute comitant esotropia. So initially I was injecting a lot in 6-nerve palsy and had like 3 or 4 years of experience there before starting out on ACE. So ACE, we had lot of patients coming in. What is the time? We have time. Okay. So we had a lot of patients coming in during the corona pandemic, much more than what we were seeing initially. And at that point of time, started trying on a couple of cases of ACE and found a really good result, in the sense that it was totally avoiding the need for surgery later on. So ACE in COVID era is mainly linked to smartphone activity, because in small children, especially in small children, even in 4 years or 5 years age group, we have seen acute comitant linked to excessive gadget usage. And more than that is like we wouldn't think, but there are very many kids who are using it even for more than 3 to 4 hours continuously, and that leads to like a spasm kind of thing, but there is no myopia. It is not like a pseudo myopia picture, but it is a different kind of spasm where you have only the medial rectus starts overacting, and then we notice the acute comitant esotropias. And see, this is another study which had come up, where you see the number of cases between it's like definitely more during the pandemic than before or after, and that is very specific for the ACE cases in one clinic. I think most of the clinics in India we noted the same problem, but the important thing is to come to the diagnosis, confirm the diagnosis of ACE. Always rule out accommodative esotropia, because the age of onset is almost similar. You have to rule out the accommodative component. you have to rule out a nerve palsy, you confirm that it is committant, and then also it is better to do MRI, because very rarely we do come across some tumors of the cerebellum, brainstem and all associated with acute committant esotropias. And spontaneous recovery is very unusual. Like we have seen lot of cases where the first visit when they come, we advise them to limit the excessive near activity. We do a cyclorefraction. In 2 or 3 cases, just by that cyclorefraction, that spasm has got resolved. Very, very rare, but it has resolved. And again, by just limiting all the device usage, it has resolved in very few number of patients. So don't advise it in the first go. Just advise them the possibility of Botox, ask them to do the cycloplegic refraction, ask them to stop the excessive near activity and review maybe after 10 days or so. If again you are documenting the same excessive near activity, then if you are documenting the same angle, then you may proceed with the botulinum toxin injection. The dose is almost the same. Only thing is here, because the lateral rectus is acting, you go for a smaller dose than what you will do in a 6-nerve palsy. So we had a series of, I forgot the number of cases. Probably we had around 50 or 60 cases where we have tried, and around 60 to 70% of the cases it was a full cure. Like we did not need to go ahead with the surgery at all. So now we are doing transconjunctival approach. So less than 20 PD, it is like 3 units, 20 to 55 and more than 56. Usually I inject only in one eye. If it is more than this angle, then we will, if it's a very large angle, then we go with the bilateral injection. And if it is working, you will know within the first visit, that is first week after injection, it will be resolved, fully resolved. If you are having a residual angle, then definitely it means that it is going to recur after maybe another 2 weeks later, it will come back to the original angle. So that is all that you need to wait for. It is very less invasive, fast recovery, very good option in variable angle, because what happens is in sometimes we do not get a stable angle. So instead of going for surgery, this will form, and this is not dose dependent. You just need to break that cycle and spasm and then it will work. There is no exact dose dependence here. But a surgery, you will need to exactly get a angle and measurement. Yeah. So again, some more role of Botox may be in infantile esotropia, but we do not see the patient so early. If we are seeing it very early, soon after the onset, then this may form an option. I think couple of people in US have tried so, and they also claim that it can sometimes cure the infantile esotropia. Sometimes if you use it in addition as a third muscle, the problem is if there is no binocularity, it is again going to recur. So I think the one thing that will help to maintain the stability of whenever you inject Botox is the fact that the patient has a capacity of binocularity and stereo acuity. If that is not there, if the child has already gone to suppression, Botox will never work. It will only be a temporary injection. Thank you.
Thank you, ma'am. Just one question, ma'am. In patients with Botox, any experience, any patients with ptosis after Botox?
Yeah, many patients can get mild moderate ptosis. Patients can get exotropia. All these things we can explain to the parent, but all these are very temporary. And we will not usually get a severe ptosis, but once we have changed to a transconjunctival approach, the chances of ptosis are very less.
Transconjunctival approach is
better. Very less, because the amount we are injecting is very less. And once you are going transconjunctival, there is conjunctiva, there is tenon, and then the muscle sheath, then you are injecting there. So the chance of it extravasating and spreading is very less.